Welcome, all of you who are joining us for this panel. We hope you enjoyed your lunch. And of course, you've already heard very eloquently what a grave public health threat is posed now to our country by opioid addiction and opioid abuse. That's really going to be the focus of this panel, how ECHO can be a platform for addressing this. And for bringing us to the point where substance abuse poses much less than it does now, the challenge to the health and well-being, not just of the United States, but of so many other nations. As we're going to hear in this panel, ECHO networks are enabling providers to be trained to prescribe drugs to treat opioid addiction and its effects at a much more phenomenal reach and a faster rate than ever imaginable. As a result of ECHO, New Mexico is now near the top of U.S. states in the number of physicians per capita who are authorized to prescribe buprenorphine under the Drug Addiction Treatment Act of 2000. That is a direct result of the ECHO intervention. ECHO is collaborating now with the American Society of Addiction Medicine on a national pilot to train healthcare providers in treating addictions, both physicians but also other health workers, such as community health workers, who can work with primary care teams to support treatment. We're going to hear about ECHO Access, which is a project that pairs nurse practitioners and physician assistants with community health workers in rural primary care settings to address behavioral health and addiction. And of course, ECHO is at work with such U.S. federal governmental agencies as the Office of National Drug Control Policy, the Health Resources and Services Administration, and the Substance Abuse and Mental Health Services Administration to extend its work even further. So we have a great deal to talk about. Let me introduce our distinguished panelists who will be bringing all these lessons of ECHO and the potential of ECHO to us today. First, we will hear from Dr. Miriam Komarmi, who's Associate Director at Project ECHO and Medical Director for the Integrated Addiction and Psychiatry TeleECHO Clinic. We're also very happy to be joined by Senator Jeff Bingaman, the former U.S. Senator from Mexico who served from 1983 to 2013, and who will bring to bear on this panel the policymakers' perspective on how to extend ECHO's reach. We're very, very happy to have with us Kana Enomoto, who's the acting administrator of the Substance Abuse and Mental Health Services Administration, or SAMHSA, who can talk from her perspective about how ECHO may continue to build out the capabilities of so many providers throughout the country to step up to the plate in dealing with this addiction crisis. Penny Mills is with us. She's Executive Vice President and Chief Executive Officer of the American Society of Addiction Medicine, and you've already heard me mention the partnership that the Society has with ECHO on the pilot. Dr. Prabhat Jand is also with us. He is professor of the Department of Psychiatry at the Center for Addiction Medicine at NIMHANS, which is a major agency in Bangalore, India. And he'll be bringing to us the international perspective on how ECHO can work not just here in the United States, but in his case in India, as in so many other places around the world, to combat addiction and offer treatment and support to those who are affected by it. We are, as the earlier panels today have done, going to have about 30 minutes of conversation among ourselves. You're going to hear from each of our speakers some of their perspectives about ECHO and its role in addiction and addiction treatment. As I say, we'll have some conversation among the panel, and then of course we will open it up to all of you for questions and additional conversation and sharing of lessons learned and observations and ideas for further extending ECHO's reach. So with that, let me turn over to Miriam to launch us on this panel.
Wonderful. Thank you so much, Susan. So In the addiction space, we've actually had projects in New Mexico for many years now. We started the Integrated Addictions and Psychiatry ECHO Clinic 11 years ago. But it's been kind of a lonely journey as hepatitis C and diabetes and rheumatology, et cetera, were being replicated around the world. We were sitting around kind of twiddling our thumbs, hoping that somebody would take an interest in addictions ECHO. And it hasn't happened until quite recently. But I think it's a case of being in the right place at the right time, or the wrong time, that addiction is so much on the national consciousness right now that we suddenly have a lot of interest in replicating ECHO for addiction medicine, and we're very, very excited to be able to share our experiences from this past decade. We also finally got around to publishing a paper on our experiences, which came out last week, and there's a link to that in the app if you want to read more about the addictions ECHO. Since the beginning, we've had a focus on opioid addiction. Long before the problem with pain pills, New Mexico has actually, somewhat surprisingly, had a huge problem with heroin addiction. Particularly in the hills of northern New Mexico, there's a generational pattern of heroin use that has torn up communities in northern New Mexico for many decades. So we were focused on promoting the training of physicians to be able to prescribe buprenorphine. So for the last decade, we've used our ECHO network to recruit physicians from all corners of the state to participate in the federally sponsored buprenorphine trainings. And we have offered, I think at this point, 15 of them live day-long buprenorphine training courses, and then have encouraged people who went through that training to participate in our addictions ECHO. As in conjunction with that, we've actually seen a pretty major change in terms of the number of physicians who have been trained in New Mexico. When we started this, there were 36 physicians who we knew of who were certified, and we've trained more than 400. Along with that, we've risen, as Susan mentioned, to near the top of U.S. states in terms of number of certified physicians per capita to prescribe buprenorphine, which we're very happy about. We have also had a focus, in addition to our Integrated Addictions and Psychiatry Clinic, which trains medical providers and primary care teams. We've also developed a curriculum for community health workers that we call CARS, the Community Addiction Recovery Support Workers Program. And we've trained about 125 community health workers to work on addiction, both in the community and to work with primary care teams to help round out the services that they can offer and help to address the many social issues that plague people who have substance use disorders. Susan mentioned the ECHO Access Program, which is a program that's been funded by GE Foundation, in which we have recruited and trained pairs, two people to make up a small team in primary care settings around the state. It's either a nurse practitioner or a physician assistant who's paired with a community health worker. And they then these are primary care folks who have an interest in addictions and mental health. And after they go through an initial intensive training with us, they spend most of their clinical time working with patients who have substance use disorders or behavioral health issues. That's been a really exciting program. These small teams are offering about 10,000 visits a year in rural New Mexico to patients for assessment and treatment of behavioral health and addiction problems. So it's a way of kind of creating a homegrown workforce that we support through our ECHO Integrated Addictions and Psychiatry Clinic to provide high quality care for behavioral health and substance use disorders. We have an exciting collaboration with the American Society of Addiction Medicine that's been funded by the Center for Substance Abuse Treatment. I won't say much about that because I know Penny will talk about it in a few minutes, but it's been a really exciting collaboration. And as I mentioned recently, other states are becoming interested in launching ECHOs focused on substance use disorder and mental health, including Connecticut, Montana, Hawaii, and New York. So we're very excited to see and help to support those ECHOs as they launch and gain traction. In addition, there's been a lot of work in the international space using ECHO for addictions, most notably in India and in Canada, where there are very large, robust addiction treatment echoes that have been helping many, many people. And I know we're going to hear from Prabhat Chand about the experience in India. The last thing I'll say is just to address a few barriers that I think really continue to plague us in this space. The first and probably largest is stigma, that addiction remains a condition in which it's socially acceptable to have and express stigma against people who have substance use disorder. And that extends beyond the general public and unfortunately also plagues the healthcare provider community and administrators of healthcare facilities. So we often hear, oh, I don't want to have those kinds of patients in my waiting room. As Leslie Hayes and I are fond of pointing out, you already have those people in your waiting room, you're just not treating them. And so we try to help change people's mind around that and encourage them to learn to provide evidence-based treatment. We also need administrators as well as primary care providers to get on board with treating addiction. And there are barriers. There's concern about the amount of time it may take initially to work with a patient with substance use disorder and the kinds of resources to address social issues and trauma, which very often is co-occurring with substance use disorder. But it's something that we need to figure out how to do because it is absolutely vital for the health of our communities. Finally, funding. As several speakers have pointed out, we need to develop sustainable funding streams for primary care providers to participate in ECHO, to learn about how to treat substance use disorder since they get very, very little training on this in their undergraduate education and their residencies. And so, serving PCPs who are not just volunteers but are actually have some kind of reimbursement funding stream to pay for their time when they participate in Addictions ECHO, I think is going to be crucial for this area as for many other areas within ECHO. I'll stop there. Thank you.
Great. Senator Bingaman, share with us again your perspective from having served in the Senate, now back home in New Mexico, thinking about the enormous impact and the enormous challenge of opioid addiction, in particular heroin addiction, as well as Miriam mentioned, in this state, and the role of ECHO in addressing it.
Well, let me first just say ECHO's done a wonderful job of trying to address a very difficult problem, which is perhaps more difficult here in New Mexico than most places in the country, in fact, almost any place in the country. I've been trying to follow what's going on in Congress and thought I'd give you a little perspective on that. I do think the issue has finally got the attention of the Congress and members of Congress, and the President deserves some of the credit for that. The general knowledge of the epidemic, the addiction crisis is much more widespread today. People are hearing about it. Members of Congress are hearing about it from their constituents. So the issue is front and center as we go into this fall election. As I think all of you know, Congress can only really take action in two general ways. One is it can authorize legislation, and separate from that, it can fund activities. On the authorizing side, there's been some progress to report in that this Comprehensive Addiction and Recovery Act, CARA, has passed the Senate this last month on the 10th of March, passed 94-1, so there's good, strong bipartisan support. I don't doubt that all members, probably including the one that voted no, believe this is a serious issue that needs addressing. The question, of course, is how do you go about getting the funding to actually do some of the things that are set forth in the authorizing legislation. The authorizing legislation, at least in the reports I've read on it, is generally well received. Everyone thinks it moves in the right direction. Everyone thinks that it moves the country toward more attention to prevention and treatment and away from law enforcement as the solution to the problem. So all that's to the good. But on the funding side, there are three big questions that I don't think we know the answers to. Well, first, on the authorizing side, we don't know whether the bill will pass the House, and that's very very much in question. There are a lot of committees it's got to go through in the House. Time is short. Election's coming, and it's not at all clear that the authorizing legislation, the CARA legislation, will in fact pass the House before the end of the session. On the funding side, there are three questions that I think always have to be asked. First of all, what level of funding will Congress settle on for the 2017 budget? The President's asked for this $1 billion in additional funding and new funding for this problem, and it's not clear whether the Congress will go along with that or something substantially less. A second question is whether whatever Congress does will be new money or whether it will just be robbing Peter to pay Paul. Some of you obviously followed what happened in the last 24 hours or 48 hours with regard to the Zika virus funding, and there, of course, the Congress took the position that they favored more funding going to solve that problem, but it had to come out of some other source, the Ebola funds that had already been provided for that purpose. So whether that happens in this case or whether Congress will actually embrace additional funding is unclear. And of course, it's also unclear as to how soon any new funding would be available. We've got a bad record in Congress of we don't do appropriations bills on time. We get, particularly in election years, we don't do appropriations bills on time. And so it's unlikely that you're going to see an appropriation that settles on what funds are available for 2017 by the 1st of October. Much more likely is that you'll have a continuing resolution that'll take you on past the election, and then, depending on how the election comes out, you may or may not have a continuing resolution that takes you into the new administration and the new Congress after the swearing in January. So there's a lot of uncertainty about the level of funding, about whether it'll be new funding, also about when the actual funding that the President is requesting or the portion of it that Congress agrees to, when it might be available. So a lot of uncertainty. I think the ECHO model is one which provides services and in a very cost-effective way, and it's an essential part, I think, should be an essential part of dealing with the addiction crisis that we face, but the extent of the funds that are going to be there to assist with that is still very unknown.
Thank you very much, Senator. So Kana Enomoto, given the situation the Senator has described with respect to incremental funding, if any, at the federal level, given the enormous challenges, tell us how you see ECHO fitting into a national strategy now to combat addictions. And let me just mention, all speakers, you can stay about this far away from the mic. It should be fine.
Thank you. Thank you for the question, and thank you to the folks at ECHO who invited me here today, but also just who are putting this focus on this important issue. When I checked into the hotel, it was really cool. This is very classy. I got a letter from Sanjeev. Maybe you all got one, but I felt special.
That's how he has so many people in the fan club.
That's right, that's right. But it said, get ready to inspire and be inspired. Changing the world fast starts here. And I see that that's sort of the tagline for the conference. And I thought it was so apropos, particularly to this issue, because the world is changing so quickly. And I think June Savili captured some of it, that in the last 10 years, last 15 years, we've seen such incredible growth in this in the epidemic. Sanjeev, I think, referenced it, 5%. It's actually, the United States is 5% of the world's population, and we consume 80% of the world's prescription opioids. And in some classes, some of the categories of medications, we consume 100% of them. And the number of prescriptions for opioids is over 250,000 a year. So that's enough for every adult in this room and every adult around the country to have a bottle of opioid medications in their medicine cabinet. And of course, many of us do have them. And so that number of prescriptions is quadrupled and doubled for adolescents. And actually, in January, my daughter had surgery on her ankle at a very renowned hospital in the Mid-Atlantic. And when she was discharged, they said she needs half a teaspoon of oxycodone every 6 hours for the next couple of days. Seems reasonable. Do you know how much I got? I walked out of the pharmacy with about this much oxycodone. So I needed, I think, 3 teaspoons is what I calculated. I walked out with half a liter, and my daughter is 11. So we're seeing a really rapid growth in this, and there's been a lot talked about what the medical schools can do, what prescribers can do, and we know that prescribers are really trying to meet the needs of their patients. They're not bad actors. They're really trying to do the right thing, but we have to do more to help them because we've seen just between 2013 and 2014 a 26% increase in the number of heroin overdoses, and in the last 4 years, in the last 4 years, a tripling of heroin overdose deaths, 14% increase in just drug overdose deaths altogether, and about 500% increase in neonatal abstinence syndrome over the last 10 or 13 years. And so the world is changing very quickly, and we as a system need to figure out how to change fast to get ahead of it. And at the department, we have a 3-pronged strategy, particularly around opioids, which looks at changing prescriber behavior. We had talked about, June mentioned the CDC prescribing guidelines. We just recently issued a funding announcement for our strategic prevention framework, RX, to link PDMP data with prevention activities. And the Surgeon General's about to issue a letter to every physician in America to talk to them about the opioid crisis and what they can do to be more vigilant. We also need to increase access to the life-saving medication naloxone, which can reverse the effects, the respiratory depressive effects of opioids. And then we need to increase access to medication-assisted treatment like buprenorphine, but also to methadone, to naltrexone, whether oral or long-acting injectable naltrexone, all 3 of the FDA-approved medications for the treatment of opioid use disorder, as well as the behavioral therapies that go along with that. And I think that ECHO can play a role in all of those. I think you can use as the force multiplying effect of ECHO to help prescribers who are trying to manage chronic pain. I know you already have ECHOs on that topic. We can use ECHO to help prescribers understand the co-prescribing of naloxone. I think you could probably also use ECHO for EMTs and law enforcement and others who might be in the situation where they're working with at-risk populations, and how do they feel comfortable administering that life-saving drug. And obviously, as we've already done, we've partnered with ACM and with the ECHO folks on a pilot project looking at how we use ECHO to increase the capacity in primary care for medication-assisted treatment, namely buprenorphine. But I think that could also be extended beyond buprenorphine to long-acting injectable naltrexone, as well as referrals to medication-assisted therapies, or to methadone and OTPs. And then I think there are other facts in terms of the reach of our workforce. About half of Americans live in a county that has no mental health or substance abuse professional. So that means that the need for the force multiplying effect for ECHO is really greater than ever. And so although we have the Mental Health Parity and Addiction Equity Act and the Affordable Care Act, so 62 million more Americans have access to a way to pay for the care. If there's no one there to provide the care, they still can't get it. So I look forward to continuing to work on projects like ECHO so that we can train both specialists as well as non-specialists and the nurses, the PAs, the community health workers, the peer support specialists to engage in that multimodal, comprehensive approach that we know can and does help people achieve recovery. Thank you.
Great. Thank you so much. And now we'll hear from Penny Mills of the American Society of Addiction Medicine, who will tell us more about these joint efforts.
Good. Thank you very much. It's a pleasure to be here. I think I first came to Albuquerque 3 years ago to meet with Dr. Karami to learn about Project ECHO, and then I'm here on a panel today to talk about our collaboration. So that's probably the story of many people in the room here, that you hear about ECHO, you think about how it can benefit the folks, the providers and their patients in a beneficial way, and then you've kind of drunk the Kool-Aid. So here I am today, and thank you very much. So I'm here to talk about a collaboration that the American Society of Addiction Medicine, who we fondly refer to as ASAM, has entered into with Project ECHO, and thanks to generous support from SAMHSA. So I think that alone shows a wonderful collaboration between a professional society, an important government agency, and Project ECHO. And ASAM, by way of background, is a national professional society. We were founded over 60 years ago. We represent over 3,800 addiction specialists and other clinicians. While our membership is primarily physicians, about 2 years ago we opened up our membership to non-physician clinicians, including RNs, physician assistants, master's trained counselors, and other clinicians. And that was recognition of it. A team delivers care for patients with addiction. Addiction medicine, though, on the physician side, has now just been recognized as a medical specialty by the American Board of Medical Specialties, which really brings recognition of addiction as a disease, and that's incredibly important for this field overall and for treatment and practice of treatment. ASAM is a professional society. We deliver education. We have our own large annual conference next week in Baltimore. We're expecting over 1,700 attendees to that event. We develop standards and guidelines, and many of our standards and guidelines are the basis of the policy and advocacy work that we do. We do it in Washington. We interact with people like Senator Bingaman and his colleagues. It's used by our state chapters, and New Mexico is our newest state chapter, as our chapters interact with policy issues at the state level. And our guidelines and standards also used at the individual patient level. We find oftentimes programs might need our guidelines to advocate to a judge or others to ensure that their patients get evidence-based treatment. So what we've done with Project ECHO, Dr. Karami is an ASAM member. She's an addiction specialist, and she's vice chair of the planning committee for something we call the Fundamentals of Addiction Medicine, which is a full curriculum that we have developed really for the non-specialist clinician, which is a different audience for ASAM. Our members, as I said, historically have been addiction specialists, but then we've opened up our membership to non-physicians. Furthermore, we recognize that no physicians or nurses learn about addiction in their training, and yet they see patients with addiction every day in their practice. And so postgraduate training is the one venue in which they have the opportunity to get this learning. You heard June Civilli talk at lunch today about several medical schools committing to including pain management training in medical school curriculum. I wish the same number of medical schools made the commitment to incorporate addiction training into medical school curriculum, but that's our next advocacy effort. But nonetheless, we've, through our planning committee, we've developed a curriculum. It's needs-based, evidence-based, and it can play a vital role in enhancing the knowledge and skills of primary care clinicians, both physicians and non-physicians, in enhancing the workforce to treat patients with addiction. So what's this pilot program now that we're doing thanks to support from SAMHSA and involvement of Project ECHO? We're calling it the Fundamentals of Addiction Medicine Pilot Recognition Program. And the program offers a combination of live education, online education, tele-echo clinic participation, and mentorship. So it's a combination of all 4 components for the clinicians that are participating in the pilot. And we have a total of 40 clinicians participating, and the program is scheduled to end by the end of next month. We recruited all of the participants out of our pilot based on their attendance at a course that we've offered immediately preceding our annual conference called the Fundamentals of Addiction Medicine course. And that course was designed based on the research that we did based on the needs for primary care clinicians. And not surprisingly, one of the key things we learned from that initial needs assessment was the negative attitudes of primary care clinicians towards taking care of patients with addiction, something that Dr. Karami already mentioned, and that being a major educational barrier to developing a curriculum for primary care clinicians. So in fact, one of the key competencies of our curriculum, and there's 9 competencies to the curriculum, is treating patients professionally and without discrimination. And furthermore, our planning committee believes that the only way that you can change attitudes by clinicians is through live in-person education. That's not something that you can do online. And that's why we felt for the pilot program, we recruited all of the participants from those who had already attended this live course and had gone through that one-day, 8-hour training that dealt with attitudinal changes as well as some basic skills and knowledge around addiction. So then, once we recruited the folks who had attended the 8-hour course, there's an additional 32 hours that comprise the pilot recognition program. And of that 32 hours, 8 hours involves participation in tele-echo clinics, including presenting a case. And each tele-echo clinic is 2 hours in length. And then the balance of the requirements, the balance of that 32 hours, after you've subtracted the minimum of 8 hours for tele-echo clinics, then there's additional requirements. That includes completing the 8-hour course that's required in order to prescribe buprenorphine. There's 2 to 3 hours that the clinicians have to take in safe opioid prescribing. And then the balance of the training is a variety of online trainings that ASAM has and a variety of topics that ASAM has: motivational interviewing, managing patients with alcoholism, a variety of other topics, comorbid medical conditions. That's all part of managing patients with addiction. And then, as I said, they have to participate in a minimum of 8 hours of tele-echo clinics, including presenting a case. If they want to do more than 8, that's certainly an option for the participants. So throughout the pilot period, there are 16 weeks of consecutive tele-echo clinics. Each clinic is 2 hours in length. The first 20 minutes of each clinic is a didactic lecture offered by an ASAM expert on whole ranges of topics, everything from managing patients with opioid addiction, the co-prescribing of naloxone, alcoholism in patients, motivational interviewing, varieties of topics. And we have the whole schedule of the didactic topics for each of the clinics on our website. And then the balance of the clinic is the participants presenting cases or listening to other cases. And then each clinic is offered the same day, each week, and the same time for 16 consecutive weeks. So upon completion of the pilot, so they have to complete the 8 hours of tele-echo clinics and the other educational requirements, then the participants will get documentation and recognition that they've completed the ASAM Fundamentals of Addiction Medicine curriculum. And then we also offer them a free year of membership with ASAM, so they're part of the addiction medicine community. So what do we see initially as some of the successes and challenges of offering this recognition program? Even without being finished yet, we've really seen a lot of great successes with this program. Certainly one of the significant successes is seeing the impact of case-based learning for the participants, both for those who present cases as well as those who learn from others who have presented cases. And for everyone that has presented cases, and we get very comprehensive documentation after every case, after every tele-echo clinic, which is part of what we actually helps us to evaluate and improve as we go go along, but everyone who submitted case has found the discussion very valuable. Furthermore, the people who've listened to the case presentations have all said that there were things that they could apply to their practice based on what they learned, and I'm just going to read some examples of those. So, for example, based on a case that was presented on an adolescent patient, one of the participants who listened to the case said, gosh, now I'm going to consider agonist treatment in opioid use disorder for adolescents that don't do well with abstinence treatment and counseling. So they didn't even recognize that that was an option for adolescents. Even other feedback, such as, I'm hearing evidence-based long-term treatment options for this chronic disorder that I wouldn't have known about otherwise. And then also a participant commenting after listening to a case that they now recognize how important it is to counsel their patients about the risk of relapse when they're in the process of tapering their patient off of opioids. So it's very concrete actions that the people listening to the cases can apply to their own practice. Another very important feedback that we get is the value of hearing from experts and participants across the country. And actually, every evaluation includes a comment that one of the best things they saw out of gain from participating was learning from nationally from experts across the country and having access to specialists. And I know, once again, reading from some of the comments from the evaluations, the learners commented about the various perspective and ideas from so many different providers across the country adds to my knowledge base and is quite stimulating. And then even the one I particularly like is when one of the participants said, it's nice to know what other providers know and also what they don't know. Because sometimes I think the participants think that, gosh, I don't know how to handle this. I don't have any confidence. And they find out even people who are very experienced don't always know how to handle patients in certain situations. That's a very important part of the case-based learning. Some of the other successes that we see even early on with the pilot is the fact that we have multi-specialty participation. It's not just physicians, we have non-physicians as well, being the actual pilot participants. But then furthermore, when we actually hold the clinics, if you ever have seen, many of you have been part of a MetaECHO clinic and you see the screens and you see the people who are participating, we see that there's multiple other people beside the pilot participant participating in the case discussion. So it's that force multiplier that Sanjeev always talks about that we see in action through our pilot. And then also the ability to link a needs-based and evidence-based curriculum with a robust set of CME and other resources with a MetaECHO clinic. So bringing that together, we think that is one of the great successes of this collaboration. And then, of course, the mentorship that happens afterwards. It's often much easier for clinicians to ask a question of an expert after they've had a relationship with them. And a MetaECHO clinic experience is a building of a relationship. And so there's that mentorship opportunity, which is another key success of the program. In terms of some of the challenges that we've seen with the program so far, certainly the timing and the frequency of the clinics is an issue because we only offer them once a week. We offer them from noon to 2 p.m. Eastern Time. It's a national pilot, so for someone who is in the West Coast and Pacific Time, 9 o'clock in the morning may not be the best time to take 2 hours off to do this. So we actually have a pilot participant that we've allowed to use participation in the integrated addictions and psychiatry clinic that Dr. Karami described earlier as a way to meet the pilot program requirements because she's so determined to get recognition for participating in this curriculum. And then the other thing we see as a challenge is scaling this up after the pilot in terms of funding to carry out the clinics more than 16 times a week, in terms of having the faculty experts that can do that, as much as 50 times a year, and then the funding for the live portion of the curriculum, because as we've said, and Dr. Karami mentioned it, the attitude and the stigma is such a key piece of getting clinicians interested and comfortable and confident with caring for patients with addiction, that we think that that's an important challenge as we think about scaling this up to implement on a national basis. In terms of how we see this fitting within the opioid crisis that we've been talking about, that we heard about at lunchtime, and that it feels as though there's not a day that doesn't go by you read about the opioid overdose epidemic in this country, we really do feel that this program, this recognition program, can play a very key role in meeting, enhancing the workforce need in this country. As we know, even just for managing patients with opioid addiction, one of the medications, buprenorphine, requires that, and it's only physicians at the moment who can prescribe it. They have to get a special waiver to do so. There's only 30,000 physicians who have a waiver, and 2/3 of them only have a waiver to treat up to 30 patients. Much of the research around why those clinicians aren't treating more patients has to do with their lack of confidence and skills in managing those patients. And we believe by enhancing their skills with this kind of program, that perhaps they'd be more comfortable in treating more patients, and that more clinicians would actually apply for a waiver. And not only will they have the skills to manage patients with opioid addiction, because our curriculum is broader than just opioid addiction, they'd have the skills for the full range of addiction that patients face. So that's sort of our overview of our pilot, what we see as the opportunities and challenges and where it fits in within the opioid crisis.
Great. Thank you very much, Penny. Prabhat, now to you. Tell us about what is going on in India.
I think thanks ECHO for inviting me to give a talk here. India is a big country of 1.2 billion people, so it's a huge country. The treatment gap is 75%, means 75% of the population does not have access to mental health, addiction, and epilepsy disorders. This is a WHO report. The quality definitely varies a lot between a tertiary center and district hospital or primary center. Now, if you look at the professional courses, in medical education course does not have mental health or addiction as a curriculum at all. Even your residency program as a MD residency program in psychiatry, most institute doesn't have the addiction as a one of the part fulfillment. And obviously stigma is a very, very biggest problem. It's Eastern culture, so things are different. But same time, the money spent from the patient is from pocket. There is no insurance system widely prevalent. So the guy has to give his own pocket to come and meet any of us. Those who, like me, who work in a federal university, being sponsored by the government of India, our salaries are fixed. We don't get paid from the patient's money. But the people who can afford to go to private sector, they have to spend a lot of money to get the treatment. And distance is a big factor. In India, you cannot cross from one part to other part. The systems are not placed. In the whole this context, 2013, when I was talking with Bruce, who is sitting here, I was telling, see, look, we train so many people, government funds it, but we don't know what is happening to the guys who go out of the training. And so Bruce was visiting India, and he told something ECHO is there. I told, where is it? I've never heard of Albuquerque. Obviously it's not a big place. Then meantime, there was a fellowship advertisement, and I applied in public health, giving this idea, let's work out, and Sanjeev, Miriam, both being mentor. I came here, spent 3 months of, place where you don't get the people at all. Contrast to India, where you get people everywhere. So it's like a completely deserted place, nobody's around. But I did it and went back. When I went back, you don't have money. So you would work without money. In sense, if I start ECHO, I don't have any resources to start. So what I did, I get some allowance for my teaching faculty. I started ECHO. The best part of ECHO, the person who is connected outside does not know where you are sitting. That is the best part of the ECHO. You can do in garage. Run it from garage. How he will know? You will see his PowerPoints. He will see your face. So that's the best part of the ECHO. I love it because you might not have a fancy place like this or ECHO Institute with a lot of resources. So we started like that actually initially, and I called my director and I showed him, see, this is how it works. And then we got a little amount of fund to get a building, and obviously ECHO supported for the software part. We started. We don't have IT professional, so we ourselves become IT. So with medical knowledge, Google, we got IT stuff and all set up. It started, and now we have 1,000 odd partners across India. So it's basically everywhere in India we got it. One good thing has happened over the time is that the mobile penetration has been very huge in India. You get a 4G connection in India. You spend around, let's say, $100. Yeah, $100 you get a 4G smartphone. So that's big, because getting a laptop, computers are expensive, and other logistic issues are there. But these are much easier to get through, and so that has changed a lot. And the Zoom that we use is compatible to all this mobile thing. So without money we started. Now second challenge, who will take your course? You want to do a lot of things, but why should I come and spend 2 hours sitting there? I have enough work to do, and all of us have to do. And particularly the person from the spoke, he thinks, let me take a rest for 2 hours. Why should I go? Summer and all. So you have to have, I call it vitamin M. Vitamin M means money. So money is vitamin. So then, but we don't have money to give. So we thought, let's have what Penny is talking about. We already done. Let's purchase a learning management solution, which is around $100, where you do a session, record everything, make some 10 questions out of the sessions and load it, and people do it like Medscape. You got some certificate and all. So we did that one. So we told, we'll give a certificate, and a certificate is from National Institute of Mental Health and Neurosciences. Now this is a big institute in Indian standard. It's like NIH of US, so a lot of money and all. So that has actually attracted a lot of people. From my side, the people who are resource persons, fortunately, most of us who work in these institutes are like-minded. We just want to do something for the people. So we got a good people who are resources, and obviously my team, they give a time to do things. So we started, and now is running. So it's a combination of real time and any time. So real time is your life, any time is whenever you want to see. And we have actually mentorship. We have done it using the social media. We use the WhatsApp. I don't know whether you're familiar or not. WhatsApp is one type of mobile devices. So this is not always active, but then people can reach to you immediately if there's a crisis happens. So some sort of mentorship actually helped, and some sort of back channel discussion with these guys helped to run it. So we started with addiction and mental health at the beginning. Then my colleagues saw, and they thought it's a good thing. So one of the perinatal psychiatrists, the psychiatrist who works in human mental health, she started second one. And the first funding we got 2 months back from the state, one of the state who asked us, can you train the doctors, health professionals? Then I asked, you give me money. So I become shameless. He asked us, I need money to do it. Not for me, but for the ECHO to sustain. So we just started, and this is the current scenario. Thank you.
Okay, great. Well, in the interest of time, I think we'll go right to questions from the audience, because we want to make sure that you have time to consult with these folks on how they are running their programs, what they've seen as the successes and the challenges, and where things might go further. And as we've heard, there's plenty of talk about. Miriam talked about the long track record that ECHO already has in this space. Senator Bingaman told us about the potential that we may have if indeed the Congress does enact the Comprehensive Addiction and Recovery Act and funds it adequately. We heard from Kana about the world changing so rapidly now that with the challenge of opioid addiction, ECHO really does represent a path forward, and the pilot with the American Society of Addiction Medicine, which SAMHSA is supporting, is obviously a key vehicle to do that. We heard from Penny that the key challenge will be scaling it up after the pilot. So again, probably taking us back to the funding issue as much as anything else. And then from Prabhat, already an impressive effort in India with 1,000-odd partners engaging in the ECHO process there. And as he noted, a great value is that the partners don't know necessarily where you are. You could be in a garage, as he said, and still carry this out. So a lot of flexibility inherent in the model. So with that, again, let's open it up to questions and comments from all of you. And once more, we do have people in the audience with mics who are able to take those questions. And again, can I see one here? Okay, Leslie.
I was hoping you'd take a quick story, which is I was one of the very first participants in the ECHO IAP clinic. I went through the first training for Suboxone, and it totally changed my career. It has been truly wonderful being able to offer this to people. And during the first year, I'm sure I called Dr. Kamarami and the other preceptor probably 3 or 4 times a month with questions when I was overwhelmed and not sure what to do, and it made such a difference in my ability to prescribe. And when people talk about the stigma also extends to the providers. I find that other providers often view me as either really gullible or, wasting my time on people who don't deserve the help, or they view me as a saint, and neither of them are true. Because of ECHO, though, I've been able to do something that I really love. And just one other comment I wanted to, Kana had mentioned the Narcan, and you can get Narcan almost anywhere in the country now, and I think everyone in this room should go out and get Narcan and carry it. I've had 2 people in my personal life who have been, one was at the grocery store and another one was at home when somebody overdosed, and they said that 5 minutes waiting for the ambulance to arrive was the longest 5 minutes in their life. And this is so easy to use, so easy to carry, it's worth getting. And then just a comment on the being able to do it anywhere, my dog's always giving me away when I try and do it at home. They always start barking frantically at something. So.
And Leslie is a primary care physician, and Leslie, as I think I heard you say when we had occasion to speak last night, you live in the county in New Mexico that has the highest rate of overdose deaths?
We're number 1 and number 5 most years.
In the state of New Mexico. In the country. I stand corrected. In the country. Okay. Great. Let's take another question or a comment.
I'll take it. I'm not shy. I'm from the pain community, and I will tell you, and Penny and I have talked before, and we've been working together, so I feel like we're working side by side in offices on the same problem, yet probably not coordinating as effectively as we could be. And when I looked, honestly, my reaction to the plan from the president and the $1.1 billion, my concern was I didn't see enough of a pain effort in that, and we liken it in the pain community to if there's a cholera epidemic, we're going to treat the cholera patients because that's very important, but we also want to shut off the supply of the cholera patients, which means we're going to go to the well water and make sure we take care of it, and pain is our well that's sort of poisoned to this point. So how can we improve coordination between addiction and pain as we're both working so hard? It sometimes is difficult to reach across. And I would encourage you all, when you start down that path, however the money's appropriated and you're able to execute, don't forget that pain is there. And I didn't see them represented in a lot of the plans so far, sort of a little bit. Please encourage them to reach back and coordinate with the pain folks to include providing them resources, because all the addiction treatment in the world and all the just saying no and prescriber regulating won't do any good if there's not options that we're trying to pay for other than opioids to make available for the largest audience. And I'd just be interested what you all think about that, and thank you.
Penny, why don't you tackle that?
Sure, I'd be happy to start. Thank you for raising that, and it's great to see you again. Actually, one of the major priority areas that our what we call our Medical Education Council has focused on is pain and addiction. ASAM's actually offered a course called Pain and Addiction for 14 or so years, and as you were talking, I thought, gosh, now there's another ECHO topic, a pain and addiction ECHO, because you're absolutely right. There's a huge intersection between the two. There are ASAM members that manage both, and there are some unique strategies in terms of managing pain and addiction, and that might be another direction to go in. But I know our education team is very interested in creating a curriculum around pain and addiction. So I think that would be a very important and interesting direction to go in.
And indeed, in a small brainstorming session some of us had last night, there was discussion about precisely that. What could be the role of ECHO in educating physicians and other providers about alternatives to opioid treatment of pain? non-drug pain treatment. And Miriam, you probably want to comment on what you think is the potential there.
Yeah, well, we have a very robust, wonderful pain echo program here in New Mexico that has then spawned a tremendous number of pain echoes around the country, huge partnership with the Department of Defense that's been highly successful. And I think it's not either or, it's both, that I think having echo focused on addictions can focus on all types of substance use disorders. Having echo focused on pain is critical for the supply side and can do a fabulous job of focusing on opioid addiction as well. So I think they're very complementary and both very needed approaches. So I agree completely.
And there's also obviously potential to extend echo beyond the healthcare space to the justice and not Justice Department per se in Washington, but the whole criminal justice enterprise and programs essentially to divert people out of the criminal justice system and into treatment programs, as is now becoming the thrust of the president's policy, as we heard earlier today. Did you want to add to that, Connor?
Yes, so I think to your point, it is there are issues around pain, as Dr. Volkow is fond of saying. We have a crisis in this country where you have parallel crises. There's a crisis of opioid addiction. There's also a crisis of managing pain, which is in some ways they're interrelated, but there's also an independent issue around pain and what we've established as a culture. Dr. Liana once said there's a pill for every pain. That is also what patients expect. There are some incentives built in. Or I think we need to look at what the incentives are for physicians to be prescribing to manage pain down to a level of 0 versus a level of manageable pain. And so exploring that as a society, exploring that as a field, looking also at the financing side when medications are easily covered and other alternative therapies are not. That limits the tools in the toolbox of the physician who is trying to be responsive to his patient or her patient. So I think we're having some of those conversations. Dr. Collins, Dr. Frieden, NIH, CDC, FDA, and CMS. We're all having those conversations in parallel. There's a pain management strategy, a national pain strategy that HHS is also working on. So I think there is acknowledgement that that there is work that needs to be done on that side structurally as well as just looking at the prescribing issue.
Great. Let's take another question.
Hi, is that on? Yeah, it's Chris Ruggam. I'm a nurse practitioner. And first, kudos to ECHO. I've sat in on a Suboxone training and called it, videoed into the clinic and that. And a question I have is for the nurse practitioners, the PAs. I really think it would greatly enhance our ability to do this work if we open up Suboxone prescribing to the practitioners like myself who are interested in doing this. And also, I think ECHO obviously has the focus, but I really, in my heart, think it would just greatly enhance the success of these interventions if there's a real emphasis on team approach to this. I know in my area there's a lot of solo prescribers of Suboxone, and it's just like every other visit. Come on in, 7 minutes later you walk out with your 30-day supply, and it really is a disservice. I don't think it's good medicine. And it is not very effective. So how do we move forward in that and getting nurse practitioners and PAs licensing for this? How best to approach it and at what levels?
Connor, why don't you take that on?
So there is actually a part of the Controlled Substances Act which requires that only physicians may prescribe buprenorphine. And in the President's 2017 budget, he did propose and request from Congress legislative action to modify that so that we could do a research demo looking at advanced nurse practitioners and physician's assistants as prescribers in communities with high needs, so that we could test the effectiveness and the safety of expanding the prescriber pool for buprenorphine. So that's in the President's budget. It's a $10 million proposal. Congress has to act in order for us to do that. And in addition to that, you're talking about sort of an interdisciplinary comprehensive treatment team, and we absolutely believe that. The acronym is MAT. It's medication-assisted treatment. It's not just M. And so it is the combination of the medication with the behavioral health, with the behavioral therapies, and those psychosocial supports, which we know are so critical to helping people achieve recovery.
Would there not also need to be state-level changes, though, in prescribing authority to nurse practitioners and as well as PAs, even if it were determined eventually through a test that it was more than feasible to have them prescribe?
I think the way we said it is that it has to be consistent with the laws of the state,
Right.
but I don't think we anticipate. I mean, because the federal statute exists, I don't know that state laws are more are any narrower. Most PAs and NPs have pretty broad prescribing authority for other Schedule II drugs.
Yeah, I was just going to say, ASAM has advocated for nurse practitioners and physician assistants to be able to prescribe buprenorphine for several years now. We support a piece of federal legislation known as the TREAT Act, which an amended version went through the Senate Help Committee a few weeks ago. We're hoping it's going to go to the floor of the Senate. Then, of course, there'll need to be a House version, but we have certainly supported and advocated for that.
Okay, great. Let's take another question here.
Hi, Miriam. You can't see me over here. It's Ann Griep. And I'm going back to the previous comment, which is in January in New York, we launched a chronic pain substance use and MetaECHO. And I have to say, regards to the gentleman who brought it up, we've had some lively discussions because, of course, the people coming, and I'm an aborted addiction person and a psychiatrist, but the people heaviest on addiction, of course, are thinking, we spent way too much time on pain and talking about what to do. You know, one of the areas I think that everything leaves out is what I'm seeing. My other role is I work for Excellus Blue Cross Blue Shield, and I'm their CMO for behavioral health. We kind of leave out that group of people that have not been, quote, misusing their meds, but have been on opiates for pain for the last 7 years, are now getting to be 60, and they probably really need to not be on it, and they still have pain. And one of the challenges is they don't fit neatly anywhere. And I think that discussions where you bring the two conflicting views have been very lively, but very helpful to our providers, because they're the ones sitting there trying to tell somebody, we have a chiropractor on our team, we have pharmacy, you know, so we're trying to integrate varieties, but it is a very challenging piece. And my question to you is, do you know the time frame of when the federal expansion is going to take effect? Like the expansion of the buprenorphine prescribing to 200. Is there a time frame?
It's currently a rule that's out for public comment, so it'll be some bit of time before we get to final. I think we're hoping to be at final by the end of the year. That's fingers crossed.
Great.
Yeah, hi. My name is Bruce Trigg. I'm a clinician. I'm sorry, I beat you.
We have time. We have time.
I prescribe a methadone and buprenorphine, and many patients I start, maybe a quarter to a half of them, have already been stable at one time on methadone or buprenorphine, but they went to jail, and they were involuntarily discontinued and then relapsed when they got out because, in many cases, they're back on a waiting list. And it's a major issue that there's very few jails and prisons in the U.S. where people have access to the community standard of care, and it really has to be addressed. I'll just say as one aside, I'm helping a local jail get a methadone license, and it is so unbelievably complex that I'm amazed that any jail would ever go through the process between DEA and CSAT and accrediting agencies and state boards of pharmacy. It has to be simplified if we're going to get treatment for people in jails and prisons. Thanks.
Great. Any comment, anyone?
It's good feedback. Thank you.
All right, let's take a question in the rear.
Yes, my name is Malcolm. I'm from Billings, Montana, and I have two main comments. The first one is I have drank the Echo Kool-Aid, and it's very tasty. Love it. So really I want to comment or say is I'm here with one of my partners, Sarah, and we are in week 5 of an Echo in Billings between mental health, addiction, and the criminal justice system. So what you guys... So all the comments that you guys are saying, I'm taking them in and I'm drinking more Kool-Aid, and I might get drunk off the Kool-Aid, but that's probably an inappropriate comment. But your comments about the shift between what they can access in the criminal justice setting and real life is one of our biggest challenges, where the appropriate medications that would help them, not just buprenorphine, but long-term appropriate medications for their PTSD or depression, they can't get those because of the formularies, and it's so frustrating to help them transition. And so I just thank you all for starting this process, and I'm going to get some more Kool-Aid in a little bit. So thank you, everyone, for what you do.
Great. Okay, I think we have time for about one more question before we wrap up. Okay, looks like there's one here.
Overdosing opioids in hospice patients to terminate them faster. That things has been in the Texas. We had few cases referred to the board, and doctors are using these opioids in large doses so that they can terminate in 2 or 3 days, because the state pays them per patient so much in hospice care, and it has become a problem. Thank you.
Well, Miriam, do you want? I think we're all speechless, frankly, at that comment.
Had another comment.
Okay.
Joan, you want to just shout it out, or here comes somebody? She's coming with them.
Hi, Joan Dewey from Indiana. I just wanted to follow up with the comments about the extraordinary measures that providers need to go through in order to prescribe methadone or Suboxone to treat addiction, when I know in Indiana, methadone was the preferred medication on the Medicaid pain formulary because it was so cheap. So to prescribe it for pain, I need nothing. And there's really little evidence base around using methadone for pain. But to prescribe for addiction, I could never do that in Indiana. So thank you. Just a comment.
One of the many barriers. All right, well, as we move to close, I just wanted to ask each of you, it's a fanciful thought, but if I could give you a magic wand of some sort that would enable you to do something even more extraordinary than has already been done or that you're already engaging in, to not only address the opioid addiction epidemic, but really to make Project ECHO front and center as part of that effort, what would it be? And Prabhat, let me start with you in India. We give you the magic wand first.
I think if you want to have measure impact, not only with addiction, mental health, or any be it cardiac disease or whatever it may be, you need people, you need inspiring people. My belief is that the technology is changing. You might get technology which may change, but you need the people to run behind the show. And if there are 1 or 2 inspiring people, people will follow it, and they will do things in the place. As Sanjeev always speaks about whole thing. So you need people, and people. That's how it is.
Great. Penny.
You know, I mentioned in my earlier comments that the American Board of Medical Specialties has just recognized addiction medicine as a American Board ABMS recognized specialty. So right now there's an effort now to grow addiction medicine fellowship programs in academic medical centers across the country. There's about 30 to 40 right now. There's a goal to have 125 in the next 10 years. I think if there was an ECHO in every academic medical center that had an addiction medicine fellowship program, I think that would truly integrate addiction into traditional medicine.
Great. Good thing to wish for, Kana, and work for.
I liked Prabhat's vitamin M. I think, and even when I first met Sanjeev, I asked, so how do you pay for it? I think finding the pay for, setting up the structure in our current healthcare system that would allow us to support collaborative care type models that's not a billable hour. How does that get wrapped in? Is it in waivers? Is it in a billable service? I'm not sure, but I think that is the trick so that we can take advantage of the force multiplication and the maintenance of quality that ECHO provides.
Great. Senator.
Well, I don't have any great insights that haven't been spoken by others. I do think that, and I think Dr. Haynes said this last evening at the dinner that I attended, there are 5 to 10 million or so people who are currently addicted to opioids of one kind or another. Is that a reasonable figure? Was that the figure you mentioned? Well, it's an enormous number of people who, and I do think if we could come up with a strategy for how to deal with that population, that would be a major step forward. I don't know exactly what that is. ECHO may be a lot of that solution. I hope so.
Miriam, last word to you.
Yeah, I think we've learned so much in recent years about the link between childhood trauma and addiction that I think using ECHO to try to start addressing the impact of childhood trauma and prevention of childhood trauma would be a really powerful upstream intervention that would be extremely exciting to do. So if there are motivated pediatricians and family docs who want to get involved in that, we'd love to talk with you. Thank you.
Great. Well, as you can hear, we may be short on vitamin M to address this situation, but there's plenty of vitamin C, C standing in this case for commitment to make a difference in this terrible epidemic. Join me in thanking this panel for a terrific discussion. Thanks.